All right, I think today's lecture is a lot of fun. It's on autonomics, the autonomic nervous system. We're going to both cut a broad swath and also shave close and wander a bit through a lot of material today. And like Tolkien said, not all those who wander are lost. So I hope you don't get lost through all of this. But it is broadly applicable to a lot of clinical aspects in medicine, and also to a lot of research topics that are quite interesting. So I guess we'll just jump right in. As usual, I like to start with a clinical question and then relate it back to the broader topics of the day. So let's say you have a 50-year-old patient who takes walks in the woods and one day notices that one pupil is larger than another. So you do a physical exam and notice that the patient's left pupil is small and non-dilatory in the dark, the left eyelid is droopy, and the left face is flush. So obviously your first question here should be, which pupil is the abnormal one? And in this case, the fact that it doesn't dilate in a darkened room suggests that it's probably the left pupil. And there's a couple interesting things going on here. A lot of these options in the answers are meant to throw you off, but if we look at the anatomy, the structure, it actually gives us a lot of insight into the actual function as well. So it turns out that neuroanatomy does come into play here. So if we take a look at the innervation of the iris, you can see here that sympathetics are coming from the hypothalamus. The primary neuron descends down through the brainstem, and then you have to remember the structure here. So remember that sympathetics come out of the sympathetic chain, which is the paravertebral chain. So the nerve ganglion that run up and down on the sides of the thoracic vertebrae, and we'll see that in more detail in a minute, but typically T1 down to about L2. The paravertebral ganglion, they house these sympathetic nerve fibers that are exiting, and that will then, interestingly, it actually forms what's called the superior cervical ganglion from T1. So it's sort of this extension upwards from T1 that forms these lower, middle, and superior cervical ganglion. And the sympathetic nerves to the eye come through that superior cervical ganglion and travel up the carotid, along with the ophthalmic artery, and eventually reach the iris of the eye. So that's how the eye is dilated. In order to constrict the eye, we need parasympathetic innervation, which comes through the cranial nerves. So in general, the parasympathetics come out the cranial nerves and some of the sacral ones, S2 to S4. Now, it turns out if you knock out the sympathetic innervation anywhere along the way, it could be the primary, secondary, or tertiary neuron. If you knock that out, then you lose the ability to dilate the eye. And this actually leads to a constellation of symptoms. Not only do you have the inability to dilate the eye, so you have a small pupil called miosis, but you also don't have innervation to the vasculature and sweat glands of that region of the face. So that can lead to lack of sweating, which is called anhidrosis. And there are also some muscles in the eyelid which are innervated by sympathetics. They're called Mueller's muscles. And when you lose innervation to those, you get a little bit droopier eyelid. So you can have a ptosis, miosis, and anhidrosis. And this is the classic Horner's syndrome. It's a classic question that comes up on the first board exam in med school. And this question in general is getting at that. This is a classic Horner's syndrome. Now the question is, why does this patient have it? So if we look at the anatomy here, you can actually see that these sympathetics run along just over the apex of the lung. Now you can imagine if there were some kind of pathology at the apex of the lung, it could conceivably interfere with these sympathetic fibers that are running directly over that region. So there's a type of tumor, Pancoast tumor, that classically forms at the apex of the lung and can interfere with these fibers. And this, interestingly enough, can lead to a Horner's syndrome. And so that's actually what's going on here in this patient. You can see when you go through the other options that were presented, they don't really make much sense, and they don't explain the symptoms or any of this pathology. So classic question, and it is really nice because it shows us the nice innervation of sympathetic and parasympathetics to the eye. Now we're going to talk about autonomic innervation of several organs, but I think this is one of the more interesting ones and has a lot of utility. Even in neurosurgery, you can imagine people with traumatic brain injuries, they get brain swelling and it can pull on the cranial nerves. So the cranial nerves that do have parasympathetic innervation, those ones will be disrupted. So when the brain is swelling and pulling on the third cranial nerve, for example, well, then you lose the ability to constrict the eye, and so the eye will dilate. And so that's called a blown pupil with head trauma, for example. Most of the time, the blown pupil will be on the same side as the lesion that's causing the intracerebral trauma, but about 15% of the time, the blown pupil will be on the opposite side as the traumatic injury. Okay, so back to the Horner syndrome. Now, there are other ways you can get a Horner syndrome. It's not only by disrupting the fibers over the apex of the lung, but it could be disrupting the sympathetic fibers by pulling on the brachial plexus. These nerves run with the brachial plexus for a brief time, and so one example of this is when delivering a baby. If you pull on the arm and or if you get a shoulder dystocia where the shoulder gets caught on the mother's pubic bone, then tugging on that arm can tear these fibers and cause a loss of sympathetic innervation to the eye. And it's interesting because if this happens early on, you tend to tear the upper roots of the brachial plexus as well, so you can get what's called an herb palsy. It's a tearing of the C5 and C6 nerve roots, and it gives this characteristic deformity with the arm. And also the lack of sympathetic innervation to the eye when induced early on as an infant or possibly as an intrauterine injury, that can cause loss of pigmentation to the eye. So normally the eyes need some amount of sympathetic innervation to darken their color as the infant ages. But if that's absent in a Horner syndrome, then one eye, the affected eye, will be a little bit lighter in color than the other. And that's something called heterochromia. So that can be another characteristic of Horner syndrome. There's actually an interesting historical case here of this happening. I usually ask students if they know what caused World War I, and they give a good answer of the assassination of the Archduke Ferdinand from Austria. But if you actually look at the motivations behind all this, so Wilhelm II was the Kaiser of Germany, and you have to remember back in this time, all these leaders of countries were interrelated. You had Wilhelm II, who was the first grandson of Queen Victoria, and he was cousins with King George V from Britain and the Tsar Nicholas from Russia. And so these cousins, they were all kind of in competition with each other, and they were all from this royal lineage. And Wilhelm II was delivered by a British doctor, and it turned out that he had this arm deformity in his left arm where he had an Erb's palsy, and this was possibly caused by the British doctor who delivered him. It could have also been an intrauterine placental insufficiency. It's not exactly known, but regardless, he held a grudge against the British people because of this inferior British doctor, supposedly, who delivered him and left him with this deformity. And that was part of his motivation to prove himself and to fight the British and declare war on the rest of the world, which initiated World War I, basically. So that's a good reason to not pull on a baby's arm when delivering them, apart from many other good reasons not to yank too hard. But Just an interesting historical application there. And we'll go through some other interesting history in this lecture as well, actually. But that's part of why you can see in these old black and white photos of Wilhelm II that he actually holds his left arm either in his pocket or on a stand or on his sword or things like that. So just kind of interesting. Now, here are a couple other diagrams showing basically the innervation of the eye. So, apart from the optic nerve, which carries the visual information, we have to have a third nerve, which does the pupil constriction, and then we have the sympathetics, which come in and join up with these nerves to do the dilation. That passes through the ciliary ganglion. So, the ciliary ganglion, if you remember, with parasympathetics, typically you have a long preganglionic and a very short postganglionic neuron right at the target organ. But sympathetics are the opposite. They have a short preganglionic, which just goes to the paravertebral ganglion, or in this case, the superior cervical ganglion. And then it has a very long postganglionic that goes all the way to the target organ. When you go to med school and you dissect a cadaver, hopefully you still get to do that. You should actually go look for this ciliary ganglion. You can find it. It's a little spidery web thing right behind the eye. So the third nerve, the nucleus, is the Edinger-Westphal nucleus that innervates the iris through the third cranial nerve. Whereas the hypothalamus is the main output center for the sympathetics, especially the nuclei in the hypothalamus, the paraventricular nuclei, as well as a little bit of the anterior and posterior nuclei of the hypothalamus. And this last diagram shows how the nerves are running through this ciliary ganglion. The third nerve obviously has to synapse there, but the sympathetics just pass right through the ganglion along with the joining of other nerves. So if you remember back earlier in the semester when we talked about the neurohistology of the brainstem, particularly of the medulla, we looked at this question about a woman looking over her shoulder and having this brainstem stroke. You'll remember this was a lateral medullary stroke, something called a Wallenberg syndrome. And this also had a lack of ability to dilate the pupil. And this was due to the brainstem stroke affecting descending sympathetic output pathways. And so this is yet another way that you can get a Horner-like syndrome, this one from the primary sympathetic neuron. And if you remember, this lateral medullary syndrome is the only place where you can get loss of pain ipsilateral to the lesion, but contralateral in the body. Other causes of Horner's could also be tumors in other areas like paravertebral masses, carotid dissections, things like that. It's anything that disrupts these sympathetic fibers. Okay, so the autonomic nervous system is incredible. Without us even having to think about anything, it controls all these systems in these incredible ways. So we have digestion. The enteric nervous system is sort of this whole separate system of neurons. It actually has more neurons than are in our brain. And it controls digestion, all sorts of contractions and secretions and things like that. We have circulation, where we have cerebral blood flow and pressure and resistance, all auto-regulated and influenced by the autonomic nervous system, both for the body and especially the heart and the brain. And then respiration. Obviously, we can exert some conscious control over this, as we probably can with most things. We can exert at least some little amount of conscious control over a lot of autonomic processes. But really, when it comes down to it, it's the autonomic system that's in charge and controls respirations. For example, when you're asleep or when you're unconscious, if things aren't too damaged. Same thing with urination. So spinal cord injury, for example, can really disrupt the ability to urinate. You might think urination is just this simple process of increasing your intra-abdominal pressure and pushing fluid out, but it's not. It depends on an autonomic process where your smooth muscles in the bladder constrict, and that is what actually expels the urine. So people with spinal cord injuries end up needing to have catheterization in order to get rid of fluid. Otherwise, they'll go into a post-renal failure because there's nowhere for the urine to go. Same thing with bowel. So when a trauma patient comes into the ER, you as an ER physician or as a neurosurgeon, one of the first things you'll want to do if they seem stable enough and you've gone through the main systems is to check a rectal tone to see if there's some sort of spinal injury. And that's part of this ASIA classification of spinal cord injuries, is do they have rectal tone? If not, it's likely that there's some amount of spinal cord injury going on. Obviously, we have autonomics involved in reproduction, parasympathetics for an erection, for example, or sympathetics for an ejaculation. We also have hormones that are regulated to some degree in the endocrine system, especially by the autonomic nervous system. We have stress responses, metabolism, for example, blood sugar and breakdown of glycogen in the liver, breakdown of fat from adipose tissue, all of this regulated by the autonomic system. It turns out that even immunity is regulated by the autonomic system to some degree. It's pretty fascinating. There's a lot of research in this area, and so I just threw up some of the more interesting aspects of this, but it can get pretty detailed, so I'm not expecting you to know any of that in there. It's just for your own interest. And then lastly, sweat is another good example of autonomic regulation of temperature and fluid. Now, here we have another diagram showing again that the sympathetic system is arranged a little bit differently than the somatic motor system. So with the somatic motor system, we have this alpha motor neuron that extends a motor fiber to skeletal muscle. With the autonomic system, though, we've already talked about this, the parasympathetics have this long preganglionic and then a short postganglionic. And the sympathetics are the opposite. They have a long postganglionic but a short preganglionic, and that's a lot easier to visualize when you just remember that the sympathetic chain, the paravertebral chain, the ganglion alongside the vertebrae are the location of these sympathetic ganglion. It's also important to note the neurotransmitters and receptors that are involved in these processes. So the somatic motor system uses acetylcholine as the main neurotransmitter, and that acts on nicotinic acetylcholine receptors, which are the fast-acting, ionic. They let ions pass through. All of it occurs very quickly to send messages to the skeletal muscle. The autonomic system also uses acetylcholine at the preganglionic ganglia. So at the preganglionic nerve terminals, they secrete acetylcholine, which acts on acetylcholine receptors that are nicotinic, both in the sympathetic and parasympathetic, just like at skeletal muscle. So these are fast-acting at the ganglia. But then we have a different type of receptor at the postganglionic neuron nerve terminal. So these are metabotropic. They involve G protein receptors, and I'll put those G proteins up a little bit later, and we'll kind of review that. But the important thing to note here is that norepinephrine is the main neurotransmitter for the sympathetic system, and that acts on alpha and beta receptors. For the parasympathetic, acetylcholine is the main neurotransmitter, and that acts on muscarinic acetylcholine receptors. So both of these, the alpha and beta for symp and the muscarinic for parasymp, those are all G protein coupled receptors. Now we'll come back to that a little bit later, but first let's just make sure we understand the overarching structure here. So this next image is actually a really high yield image, and it's a really well done image that shows sort of the layout of sympathetics and parasympathetics. This might look really simple at first, but there's a lot of interesting things to note here. So one of them is what we've already talked about, the innervation to the eye. You can see that on the sympathetic side, the sympathetic neuron is extending out from the superior cervical ganglion, and that is not labeled here. A lot of these ganglion are not labeled here, and you don't need to know them for the exam, but it is useful to point them out. So This ganglion sends sympathetic nerves up to the eye, as well as to other things in the face, so the salivary glands, for example. And then on the right side, you can see the parasympathetic innervation coming from the third cranial nerve, and that again passes through the ciliary ganglion, which again is not labeled here, but this is worth going through for each and every organ. So you can see that the cranial nerves are the primary parasympathetic innervation for basically all the major organs. It's fascinating to think that so much parasympathetic innervation comes out of the cranial nerves, and particularly the vagus nerve, which extends down to the lungs, the heart, even the intestines, the pancreas, digestive tract, the gastrointestinal tract. So this is a really interesting sort of network. Almost every organ is innervated both by sympathetics and parasympathetics, but you can see there are a couple exceptions here. Notably, the vasculature, so blood vessels especially, are only innervated by sympathetics. And same thing with the sweat glands. The majority of sweat glands in the body are only innervated by sympathetic innervation. So most organs, it's sort of a balance between sympathetics and parasympathetics. It's whichever system is firing more rapidly and signaling stronger through the receptors. But in some cases, it really only depends on the activity within one system. Now, there is a little bit of a roundabout here. So the vasculature, for example, there are acetylcholine receptors on the endothelia of the blood vessels that can then do this downstream indirect signaling of nitric oxide release and dilate the vessel. But we're gonna skip over those little complexities, and we're just gonna say vessels are innervated primarily by sympathetics, because that's what really is clinically relevant as well. And we'll see examples of this towards the end of the lecture. Another interesting thing here is the innervation to the adrenal gland. So you can see that there is a preganglionic neuron on the sympathetic side going to the adrenal gland, but there's no postganglionic. It turns out that whatever events occurred evolutionarily, the adrenal gland, it may have been a postganglionic neuron, but it's formed into this gland instead that can secrete neurotransmitter not into a nerve terminal, but into the bloodstream directly. These neurotransmitters are the basic sympathetic neurotransmitters. So norepinephrine, for example, is one that's released into the bloodstream. Also epinephrine. These are sometimes called adrenaline and noradrenaline. They're the same thing. They are secreted into the bloodstream directly, and they can travel to organs through the bloodstream rather than through nerve terminals. You can also see here that if you lose sympathetic innervation, for example, from a spinal cord injury at the thoracic or higher level, then you'll lose the ability to vasoconstrict vessels. You'll lose the ability to speed up the heart, and those two things can lead to a loss of blood pressure and a loss of cardiac output that can result in spinal shock. Now, when I say spinal shock, I don't just mean that the spinal cord has been shocked or that you're in a state of stupor from a traumatic event. Shock literally is meant to mean that there's not enough perfusion to the organs. So this lack of perfusion, this lack of ability to maintain a blood pressure is characteristic of someone suffering a high spinal cord injury when they come into the trauma bay. Also, you can see why they would lose sympathetic tone and why sometimes they would lose rectal tone and also have a priapism, meaning a sustained erection, because they've lost the sympathetic tone from the spinal cord injury. Now, this next image shows a little more detail on the ganglia names and what organs they specifically go to, so just kind of a useful diagram there as well. And then similarly, this diagram is showing a basic overview and summary of what we've already talked about, with the sympathetic location of the preganglionic being in the thoracolumbar region, and the length of the pre- and postganglionic neurons, and then also the basic functions here. So sympathetic is catabolic, meaning breaking down nutrients, getting them ready for the fight or flight response, so to speak, whereas parasympathetic tends to be more about anabolic, building things up, resting and recovering. Now, this is sort of a diagram showing that the autonomic system is regulated at multiple areas in the brain. I gave the example earlier that the main control center is the paraventricular nucleus of the hypothalamus, and that's true, but it is important to note that several other centers are integrated into this, particularly the reticular formation in the brainstem, and also a lot of functions that are regulated through the spinal cord even. And you can imagine, for example, there have been times where I'm on a run up the canyon and going along, and all of a sudden there's a snake on the trail, and before I've even registered that that's a snake or what kind of snake is it venomous, I'm already like jumping out of the way and having my heart beat out of my chest. And these responses can be extremely fast and effectively subconscious in a way, even before you realize what actual threat you're facing. So you can imagine in that scenario, it's useful to have a catabolic reaction to break down sugars, to get the heart beating faster so you can run away more quickly and things like that. So pretty fascinating responses there with the autonomic system. Now we're going to talk about the actual sympathetic and parasympathetic receptors here. And I do this not to be tedious. I really don't want to do this, but it turns out that it's immensely useful for understanding the actual clinical effects that we see in the sympathetic and parasympathetic systems. So I think this is really essential to understand. And this might seem a little bit tedious at this time to go through, but you'll see as you progress in your medical education that this actually becomes something that you don't even need to think about, that just makes intuitive sense to you. So it's a little bit painful at first, but it's totally worth it. So that's why we're going to talk about it. Okay, so alpha-1 receptors. When these are present on smooth muscle, they tend to initiate muscle contraction. So examples of that include gastrointestinal system, the bladder, also vasoconstriction and venoconstriction with sympathetics, and also pupil dilation. The pupil dilation working primarily by the radial muscles in the eye that contract and pull the iris open. And that's opposed to the parasympathetics, which will be a smooth muscle contraction of the concentric rings near the center of the pupil, or near the center of the iris, and that will pull it closed. The alpha-2 receptors are really interesting. It's kind of complicated, and I'm not going to make you guys know this for the exam, but alpha-2 receptors are primarily involved in central nervous system mixed effects, I'm going to call it. So some examples of this, if you have a drug that activates alpha-2 receptors like dexmedetomidine, it has these unusual sedative and analgesic effects because it's effectively eliminating sympathetic output. And so this causes the inability to transmit certain pain messages up the spinal cord, and also to suppress sympathetic outflow that maintains awakeness and awareness. So strangely, an alpha-2 agonist can be an analgesic and sedative and lower blood pressure and all these interesting things. All right, the next set of receptors are the beta receptors. So beta-1 mediates primarily cardiac effects, including increasing chronotropic, dromotropic, and inotropic effects. Chronos referring to time, dromos volume, and inos force. So interestingly, the sympathetic system can change not only the speed and force of the heart contraction, but also the volume and the shape of the heart even. So sympathetic output primarily drives increased cardiac output overall. Every one of those things, the increased speed, increased volume per pump, and also the increased force of contraction, all of those will increase cardiac output. The next receptor is the beta-2 receptor, which is primarily involved in smooth muscle relaxation, for example, in the bronchi of the lungs. So you can actually give a drug that acts on beta-2 receptors specifically. For example, albuterol activates beta-2 receptors and causes dilation of the bronchi. So, for example, someone who's having an acute asthma attack or some sort of bronchospasm, you can give albuterol, a beta-2 agonist, and dilate those bronchi. Beta-3 is also an interesting one. This seems to be primarily involved in lipolysis, and as you can imagine, pharmaceutical companies have been trying to find some agent that is specific to beta-3 because it would be a fat burner, and that would be a multi-billion-dollar drug. But so far, they've been unable to make a drug that's either specific enough to the beta-3 receptor or that doesn't have unwanted side effects. This can also be involved in certain glucose responses and bladder effects and things like that. Now on to the parasympathetic receptors. The muscarinic 1 receptor is primarily involved in salivary gland secretions. The M2 receptor, that's the cardiac effector, so decreased heart rate, decreased contractility, decreased AV conduction. This is kind of the opposite, not exactly, but somewhat the opposite of the beta-1 receptor. The M3 receptor is smooth muscle contraction. So, for example, the pupils, the concentric rings of smooth muscle that pull the pupil closed, as well as the bronchi. And then also an indirect signaling mechanism, which I mentioned briefly earlier about acetylcholine receptors acting on M3 receptors to induce nitric oxide release in endothelia of the vasculature and causing vasodilation. The M4 and M5 receptors are primarily, they primarily result in central nervous system effects, mad as a hatter, so to speak. So those are kind of mixed and complex. Now, as we talked about before, these all act through G-protein coupled receptors. So, for example, alpha-1 acts through GQ proteins, which acts through the phospholipase C pathway that activates DAG and increases IP3, which then activates PKC and increases intracellular calcium. Alpha-2s are primarily the G inhibitory protein, which decreases cyclic AMP, and that can decrease intracellular calcium and increase intracellular potassium, for example. And then the beta receptors are all G stimulatory, which does the opposite of G inhibitory. It increases cyclic AMP, which activates PKA and MAP kinase and things like that to increase intracellular calcium. And then with the parasympathetics, these are primarily G inhibitory and GQ. They act through the same mechanisms, of course. So that's a lot of information, and the real question here is, how do we apply this? So I think the best way to teach this is simply to go through some examples, and I've tried to pick out several examples both from my own clinical experience and also from everything from board exams and physiology and all this stuff, and tried to make enough examples that I cover everything that I think is important and cover enough that you see an application to all these different receptors. So we're going to go through probably 8 or so examples, and hopefully it's helpful to understand how these receptors are actually working to exert these unique and specific clinical effects that we typically see. So for the first example, I thought I would start off with another historical example of King George VI. I don't know if you've seen The Crown on Netflix. It's one of the most expensive TV productions ever made, and it's all about the history of the royal family in Britain. And it starts off with King George VI, and he's kind of coughing up some blood, and he's a smoker, and back then they didn't tell people when they had these terminal diagnoses like lung cancer. So the family and the doctors, they're trying to be optimistic, but they tell him he needs this operation. And back then, these surgeons were incredible. I mean, the boldness to basically convert Buckingham Palace into an operating theater and do a pneumonectomy in Buckingham Palace. They go in and they take out part of his lung that has cancer, hoping that they'll prolong his survival. Now, pneumonectomy is kind of a nightmare sort of post-operative thing to manage in the ICU even nowadays in a modern hospital. So doing this back in Buckingham Palace with these old school hardcore surgeons is really incredible. And King George, he not only had lung cancer, but another aspect of smoking is peripheral vascular disease. In fact, it's much more common than getting just lung cancer. And this peripheral vascular disease, it results in these sort of stenotic arteries. And one symptom you can get is called claudication, meaning that it hurts to walk. Your legs get ischemic as you try to walk anywhere. It's like tying off your vessels and then making you run. It would really hurt because your tissues aren't getting enough oxygen and glucose, and they're not perfusing well. So what they did is they snipped a particular nerve to treat this condition. So try to think in your minds, what nerve would you cut in order to alleviate this sort of stenosis of the peripheral vessels in the legs? Well, what they did was a lumbar sympathectomy. They cut the sympathetic nerves going to the lower extremities. So since there's a loss of sympathetic tone, there should be less vasoconstriction, and presumably the artery should dilate. And this did alleviate his symptoms, and it also resulted in other symptoms. So try to think what other symptoms or sort of side effects you would get from this procedure. Well, you can base it all just on how the innervation is structured. So if you cut sympathetics, you also lose the ability to sweat, which means that you will retain more heat. You can't regulate your heat as well. And you can get hyperhidrosis or more sweating in other regions of the body that are still innervated. So in your axillary region, for example, you could get more sweating to compensate for the lack of sweating in your lower extremities. So some pluses and minuses there. You can actually do this as a procedure still today if you have sweaty armpits or sweaty palms and it affects things that your job depends on, for example, performing on the piano or public speaking or things like that. Some people do still have a sympathectomy to alleviate hyperhidrosis, to excessive sweating. And you can do this not only with surgery, but also with an injection through a needle of a numbing agent that numbs the sympathetic nerves, for example, so a localized anesthetic. The second example involves this crazy incident in a public airport. Kim Jong-un is the leader of North Korea, and he has a half-brother who was killed, and he was approached in the airport by these ladies who put something over his face, and he started coughing and started having difficulty breathing, and went to get help at the medical services desk in the airport, and quickly died. So we have surveillance video of this incident. It's widely thought that Kim Jong-un had him murdered, and the agent that they used is this VX nerve agent. So it is one of the most potent nerve agents that we know of. It's an acetylcholinesterase inhibitor. So it has cholinergic effects. It's an overdrive of the acetylcholine neurotransmitter. So as you can imagine, these cholinergic effects result in salivation, lacrimation, bronchoconstriction. It's like trying to breathe through a straw. They slow down the heart. They cause pinpoint pupils. And they can induce diarrhea, urination by all these secretions, for example. So this is a horrible way to die. This is part of why nerve gases are prohibited by the Geneva Convention. And as you can imagine, the best way to treat this would be with an anticholinergic agent. So atropine is one of the classic anticholinergics, and it basically blocks the effects of the excessive acetylcholine at the synapse. So quite interesting to see this clear example of physiology in modern times. Now, it's kind of useful here to take a quick step back and note the effects of catecholamines on these receptors. So norepinephrine is the neurotransmitter. It can act on all receptors, on all sympathetic receptors, the alphas and betas, but they tend to have a specificity. And it turns out when they're in the blood, it's a little bit different than when they act at the synapse. As far as clinical effects go, we can make an assumption
that norepinephrine essentially acts only on alpha-1 receptors, whereas epinephrine will act on all receptors, alpha-1, beta-1, and beta-2. Now, this might seem weird, but it actually explains a lot of the strange and sort of counterintuitive effects that we see from acting on these receptors. So since alpha-1 is primarily the receptor in the vessels, when you activate alpha-1 receptors, you get an increased peripheral resistance, you get a vasoconstriction, and this is why with both epinephrine and norepinephrine, you increase blood pressure. Now, epinephrine, when it activates beta-2 receptors, it will cause a little bit of vasodilation. Those beta-2 receptors tend to be in the major vessels to major muscle groups, and this actually makes logical sense. If you need to run away from a lion or a bear, you need blood flow to your major muscle groups. So epi does have a little bit of vasodilation properties in certain vessels and certain muscle groups, and that can be potentiated or inhibited under certain conditions as well. It gets complicated, but for our purposes, just both epi and norepinephrine can vasoconstrict, and their predominant effect is vasoconstriction and increased vascular resistance, which elevates the blood pressure in both of them. This is also why epinephrine is such a great drug for resuscitations. It increases blood pressure whether you've lost a lot of blood or whether you're septic or some other problem. It immediately restores pressure and therefore at least hopefully perfusion of organs. Now you also need to be pumping blood, so you need an increased cardiac output. Epinephrine does a good job of that, so it'll increase heart rate. And as we talked about, it increases the inotropic and dromotropic and chronotropic effects on the heart. So that's altogether resulting in this massive cardiac output. Now, of course, if your heart is damaged or ischemic or limited, there's going to be problems with giving epinephrine, of course. But let's just stick with these simple examples. Now, norepinephrine has this sort of counterintuitive effect. Because it primarily acts only on the alpha-1s when it's present systemically through the bloodstream, we have this interesting sensor in the carotid body that detects pressure, and it says, whoa, pressure is really high. I guess I don't need the heart to beat so much. So it regulates, it sends a signal back through the hypothalamus, this feedback signal, and says, whoa, you can slow the heart down. It's okay. We don't need to pump so hard. And so, ironically, with norepinephrine, we actually get a decreased heart rate. And you'll see this if you're ever shadowing an anesthesiologist and you need to use these drugs, pay attention and notice that these effects are very strong and immediate. So norepinephrine will do the opposite of epinephrine. It will actually slow the heart down. Now, if this all gets confusing, try to just simplify it by thinking back to the pressure-flow equation where pressure equals flow times resistance. You can imagine if you vasoconstrict, you're increasing peripheral vascular resistance, you're increasing R. And if you're increasing cardiac output, you're increasing flow. So if you're increasing both of those things, you're obviously dramatically increasing blood pressure. So here's a list of some more alpha and beta receptor actions. So beta-2 agonist like albuterol we already talked about, it's a bronchodilator. A beta-1 agonist, for example dobutamine, can be used to increase cardiac output, and this can be used in a cardiac stress test, for example, like say someone can't run on a treadmill, but you want to see if their heart has, if they get chest pain or if their heart has any ischemia during exercise. We can use dobutamine to effectively pharmacologically exercise the heart, or in cases, critical cases in the ICU, for example, use dobutamine drips to continually make the heart pump harder. Now, all of these, I put examples of these drugs in parentheses. You don't need to know the drug name or action or anything like that, but just understand the mechanism. That's what's important. So on the exam, I may throw drug names in, but don't let that confuse you. What's important here is what the mechanism of action is, like beta antagonism or beta agonism. Okay, so a beta antagonist, like a beta blocker, like metoprolol is kind of an old classic one, these can be used to be cardioprotective. And, there's a lot of drugs that are in medicine, that are used in medicine frequently, that really aren't that effective or that have questionable data behind them. But beta blockers are actually one of the most effective drugs that have proven time and again to be effective. And what they do is they lower heart rate and blood pressure. Now, it's interesting that exercise obviously increases heart rate and increases blood pressure. So why is that such a healthy thing? Well, it seems to be that it's periodic and that it induces a different type of stress on the cell than to have chronic, ongoing hypertension, high blood pressure that's constant and that never has time to recover, and that puts a large afterload on the heart. And so the heart is always having to beat against it. So interestingly, by lowering blood pressure and lowering the ability of the heart to overwork itself and have too much sympathetic tone, it actually imparts a protective effect on the heart and therefore a longer lifespan. And interestingly, blocking that sympathetic innervation can actually remodel the muscle of the heart itself to be more efficiently modeled, more efficient architecture, which is really interesting. You can also imagine that beta blocker has the effect of limiting sympathetic outflow during times of anxiety or nervousness, so they can actually reduce tremors, and some people use them before performances, for example, to calm their nerves. And also, I actually had an interesting experience with this once with my father-in-law. We were working in the yard together, and he started feeling lightheaded, didn't feel well, and I thought I should do the doctorly sort of thing and check his pulse and see what was going on. And interestingly enough, it was actually totally irregular. It was bump, 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 bump. And I just knew right away that he was probably in atrial fibrillation just from feeling the pulse. The first line treatment for this atrial fibrillation, you want to cardiovert them if you can, pharmacologically preferably, because doing it with shocking paddles is not comfortable at all. But fortunately, he was able to be cardioverted quite easily, and now takes a beta blocker just to prevent any reactivation of the atrial fibrillation. The next example is with a non-selective alpha and beta antagonist. An example of this can be phentolamine. And I thought an interesting application of this is actually in dentistry. So if any of you are going to dental school, you've probably already shadowed a dentist and probably already seen numbing agents like lidocaine or bupivacaine. And these work obviously by, as you've learned, by inhibiting the sodium channel and preventing nerve transmission. But patients don't like to go home with a numb mouth, and so sometimes there are dentists who will use phentolamine as sort of a reversal agent, but it doesn't work directly by reversing the numbing agent. Instead, it works by vasodilating and washing out the numbing agent. So you've probably seen that in a numbing agent, you put in epinephrine typically, and what this does is it vasoconstricts the vessels so that they don't wash out the numbing agent. When you put epinephrine in, it makes the numbing agent like lidocaine or whatever numbing agent you're using last longer in the tissue. Now, obviously, you shouldn't use epinephrine in the tips of things, so like in the tip of a finger or during a circumcision or something, because it can make the tip become ischemic and die and fall off. So use epinephrine only in tissues that are well vascularized, but it essentially makes the numbing agent stay longer. So when you use phentolamine, it is an antagonist of alpha-1 receptors, for example, and it can cause this vasodilation and effectively wash out the numbing agent and reverse its effects faster. Also, if you have the excessive release of catecholamines into the blood, so you have a massive amount of norepinephrine and epinephrine causing vasoconstriction, what you prefer to do in that case for long-term management is to inhibit both alpha and beta receptors. Now, in the acute stages, you actually want to inhibit the alpha receptors first, because if you inhibit beta, you could theoretically worsen the hypertension by inhibiting the beta 2 receptors, which we talked about how they vasodilate large vessels. So first you do an alpha 1 inhibition, for example, down at the bottom with phenoxybenzamine, and then this will first do alpha blockade, and then you can then also block beta receptors. So this type of scenario can occur with a certain type of tumor, pheochromocytoma. It's an adrenal tumor that releases norepinephrine and epinephrine into the bloodstream and causes these sorts of bouts of high blood pressure. So understanding the physiology here is obviously quite important. The next example is an alpha-1 antagonist, for example, prazosin. So these can result in everything you would expect from inhibiting the alpha-1 receptor. So sometimes they're used to pass kidney stones out the urethra, so they'll dilate the urethra. And as you can probably guess, they can also be used to lower blood pressure. And then the last thing on this list, the alpha-2 agonist we already talked about, dexmedetomidine, also clonidine. These can be used as antihypertensive agents, but dexmedetomidine is primarily used by anesthesiologists, and not even that many anesthesiologists. But if you ever shadow an anesthesiologist, you should ask if you can use it on certain conscious sedation patients or certain cases. And you'll see that it does really act in all these different ways. It can simultaneously be an analgesic, a sedative, and it works by decreasing sympathetic outflow. Okay, the next clinical example we've also already talked about a little bit. So with a spinal cord injury, as you can imagine, anything above the thoracic level is going to inhibit the thoracic output, including the sympathetic chain. So as we mentioned, when someone comes into the trauma bay with a spinal cord injury, they will typically have a low blood pressure, a low heart rate, and all the other signs that we talked about, low rectal tone, possibly priapism, and this is caused by the inability to vasoconstrict and also possibly the inability to speed up the heart. We actually looked at an image of this last week on the MRI imaging lecture. So this person had an anterospondylolisthesis at C6, so you can see the C6 vertebrae is moved forward off of the C7 vertebrae, which leaves this massive disc and also some ligament that is essentially compressing the spinal cord and leaving this person as a quadriplegic. So with these injuries acutely, you expect a sort of spinal shock. Now, it's also possible that this can, over time, especially with any injury above the T6 level, it leads to a loss of sympathetic tone, and yet when you have certain factors that would normally be painful, for example, a very full bladder, like let's say someone is unable to urinate because of the spinal cord injury and they need to catheterize, but they can't sense it because they don't have sensory nerves that ascend through the spinal injury, so they can't sense it, but it still causes this what's called autonomic dysreflexia. And so with a massive uncomfortable stimulus, like a full bladder, it can actually cause this dysreflexic response, this sort of apoplectic release of neurotransmitters all at once. And you can get release of norepinephrine and acetylcholine all at once. And this can effectively lead to a massive increase in blood pressure from the norepinephrine. Now, the acetylcholine that's released, that, as you might expect, can slow the heart rate and lower the blood pressure. And norepinephrine, remember, while it's raising blood pressure dramatically, also slows the heart. So you can get this very bradycardic response, a slow heart rate, but massively increased pressures. Now, in the later phases of this, when the norepinephrine has slowed the heart rate as well as the acetylcholine, you can actually get a lowering of the blood pressures. But it's sort of this disjointed, chaotic autonomic output that can induce all these weird effects of either raising the heart rate or lowering the heart rate. Similarly, back on the pheochromocytoma, where you can get this sort of surge of release of epinephrine and norepinephrine, depending on which one is more predominant, you could either get an increase in heart rate from the epinephrine or a lowering of the heart rate from norepinephrine, but either one is going to dramatically increase the pressure. Now, for the last example, I just want to use something from the hospital. So when you write orders for patients, you'll typically write orders on admission or adjust orders on rounds, and then you'll be in the operating room for a long portion of the day. And so it's nice if you can sort of anticipate things and not be called on every little issue by the nurses. So you can write orders that anticipate certain little problems. And one of these involves some of this autonomic physiology. So this little chart here shows how a patient could conceivably have high blood pressure and a low heart rate, or a high blood pressure and a high heart rate, or a low blood pressure and a low heart rate, or a low blood pressure and a high heart rate. Now, if you can write orders for all these scenarios all at once, it'll save you a lot of time and headache for most simple things. Now, obviously, if it's severe or there's some underlying cause that you're worried about, then it's a little bit different scenario. But generically, you can write these orders. So we'll just kind of go through them and look at the examples. So if someone has a high blood pressure and a low heart rate, that's an example that we haven't really talked about here, but you would use a direct vasodilator, so hydralazine or something like that, because that would effectively lower the blood pressure, and in response, the heart will beat faster. Now, if you have a high blood pressure and a high heart rate, that one we have talked about. That can just be a simple beta blocker. You're effectively blocking beta receptors and thereby lowering blood pressure and also slowing down the heart. So it takes care of both problems at once. Now, if you have a low heart rate and a low blood pressure, this is kind of something you tend to worry more about in the hospital, because typically bad things can cause this sort of scenario. But if it's within certain parameters that aren't too worrying, you can give certain medications, like epinephrine. Now, that's typically a strong drug. If you gave that to any reasonably healthy person, they would jump up off the bed. So that's typically reserved for severe resuscitation type scenarios, or anaphylaxis and stuff like that. Also, there's another lesser form of the drug, ephedra, which kind of helps you release your own epinephrine from your adrenal gland. And this has actually been used as a diet pill as well to sort of accelerate your metabolism and things like that. But of course, it can induce heart attacks as well. So it's kind of off-label use of that. But anesthesiologists often have this on their cart during any sort of sedation in the operating room, because typically the anesthetic agents will drop your blood pressure, and you can restore that pressure and restore the heart rate by giving ephedra, or if it's very severe, you can give epinephrine. Similarly, when you give an epidural, you are like for example in a birth, you're numbing the thoracic region, and that can numb the sympathetic nerves. So you can get a vasodilation and drop your blood pressure and decrease perfusion, and you can slow down the heart as well, because you're numbing the same nerves that could go to the heart, assuming that the epidural goes, too high. Typically, you want it from the belly button down, but sometimes the fluid just leaks up that epidural space higher, and it can numb the entire thoracic column. So you actually get similar effects from an epidural as you do from a spinal cord injury, for example, with the sympathetic blockade. All right, so now if we have low blood pressure and a high heart rate, what we want to do there is use something that raises the blood pressure and lowers heart rate. And we already know a drug that does that. It's the neurotransmitter. It's norepinephrine, or noradrenaline as it's sometimes called. So that also is a very strong drug. So you can use a lesser version of that one. It's called phenylephrine. and that will act in a similar manner, and it will raise blood pressure and thereby lower heart rate. The same mechanism we talked about before. The carotid body senses a higher pressure and it slows down the heart through a feedback mechanism. Now, sometimes these same medications can be used in drips. So, for example, if someone is totally unable to maintain a blood pressure, for example, think of sepsis, where you have all these lipopolysaccharides that are causing massive vasodilation and leaky vessels, you can use epinephrine and norepinephrine to tighten up those vessels, to vasoconstrict and restore blood pressure. Now, sometimes you can overconstrict, and so sometimes people on these pressors, as they're called, the vasopressors, they'll get ischemic limbs, like ischemic in the hands and the feet, and you end up having to amputate them. But at the same time, you are saving their life by maintaining perfusion through these organs. And so this shows a typical setup. This one's actually a pretty advanced setup. This is in the neonatal ICU when I was on pediatric surgery. And these cases can be quite severe. And actually, one of the first patients that I ever saw die when I was a third-year medical student was I was on my trauma surgery rotation at the county hospital, and this elderly lady had come in with abdominal pain, and the intern who was on call that night had written some quick orders and not thought much about it, but we think that she kept eating food, but at the same time she was unable to maintain her blood pressure later that night, and we started pressors. But when you have food in your intestines and you start pressors, you're vasoconstricting and yet making your intestines do a lot of work to move the food through. And so what happens is the same thing as the claudication that we talked about with King George. You put these high metabolic demands on the tissue, and yet you cut off the blood supply. And so this lady actually got ischemic in her bowel, and in the early morning hours around 2 a.m., we took her into emergency surgery and opened up the abdomen, and the intestines had already started leaking everywhere. So it was a mass of blood and stool, and we couldn't find the bleeders, and the whole intestine seemed pretty ischemic, and so it was just a lost cause, really. And it all results from not understanding the basic autonomics here, that you can't have fed someone and also put them on pressors. And this is just one of those things that they don't really necessarily teach you about in med school. You hopefully learn somewhere along the way. And of course it creates all sorts of other complications. How do you feed people in the ICU? It can be really challenging. You have to do this total parenteral nutrition, but that has other complications. So the ICU is all about logistics and anticipating the many interacting complications that can occur, and so much of it involves autonomics. Another case I had involved a man who had suffered massive neurological trauma, and he was on a couple pressors and started having some significant neurological changes, and so I sent him down for a CT scan. And while I was handling some other stuff, a call came back up to the ICU desk, this panicked call saying that the central line had pulled out of the patient while he was run through the CT scanner, and that he was crashing in the radiology department. So I had him run to the elevators to bring him back up to the ICU, and I ran over to the storage room, grabbed a central line kit, and as I ran out of the ICU, just threw some hand sterilizer on my hands and met them at the elevator. And I threw in the fastest subclavian central line that I've ever put in. It only took a few seconds, and hooked back up the pumps and restored the pressors. And immediately his pressures came up, and surprisingly, he survived that episode. Unfortunately, later on, his injuries were so severe that the family did make the difficult decision to withdraw care, due to the fact that he would likely never recover and would certainly suffer a long, prolonged series of complications and downhill course that would most likely lead to a lot of pain and suffering and death in the end anyway. So I hope that's a good overview of the autonomic nervous system and how it applies clinically and how it's used and thought about clinically. Hopefully that introduction will give you a lot more insight so that you kind of build your foundation and your architecture of how you think about these things, and then later it'll be a lot easier to add more details to your shelves and in a logical and coherent manner. So for today's lab, the question is, how are we going to study autonomics? Well, what we're going to do is a polygraph. Now, a polygraph just literally means multiple graphs. You're recording multiple things, but it's often referred to also as a lie detector test. So what we're going to do is extract multiple biosignals from the body, and these biosignals can include a lot of things. Today it's going to include electrocardiogram, respiratory measurements. We're not going to do a pulse ox because that's not as relevant to a lie detector test, but in the hospital it certainly is relevant. And there's a whole interesting thing there with the technology that's used for obtaining pulse oximetry, but we won't go into that today. And then blood pressure as well. And sometimes electroencephalography is used in this also, but we'll do that as a separate lab. So the last important signal that we're going to extract is something called the galvanic skin response or electrodermal response. And this is something that seems simplistic. This whole lie detector thing might seem like old school, outdated, but surprisingly, it's still used a lot. The Pentagon still performs a lot of these. The CIA certainly does. There's movies about how to defeat it, like Angelina Jolie and Salt trying to deceive the lie detector test by modulating her autonomic output, or having distractors like giving yourself a pinprick or pain to throw off these autonomic responses. But these are also used in a lot of research still too as well. Some of that involves biofeedback, for example. So having some sort of measuring tool, whether it's electroencephalography or electromyography or electrocardiography, and trying to learn to put your state of mind in somewhere where it modulates these signals to be in a desired state. So trying to be in a state of calmness, for example, with soldiers who have suffered PTSD. I know my brother has done a lot of this biofeedback. He served 3 deployments in Afghanistan as a Marine, and this biofeedback stuff has helped him. But as of yet, there's not enough. There's not a large enough collection of data to show definitively what its utility is or who it's effective on. But that research is certainly ongoing and hopefully beneficial. So the basic galvanic skin response is just 2 electrodes that are placed on the fingers typically. And as we mentioned, sympathetics innervate sweat glands. So if you have some sort of stressful response or you're having to think a lot about how you're lying and deceiving, it tends to elevate the sympathetic outflow, which induces more of a sweating response. And that sweat, which contains ions and water, it will reduce the resistance, or in other words, increases conductivity. And so all we have to do is measure these voltage fluctuations, and typically we'll correlate that with other responses like the electrocardiogram, respiratory rate, and EEG. This next slide shows the basic circuitry. So you can see the 2 finger electrodes, and it goes through this bridge which helps accurately detect a change in resistance. Then it has a buffer amplifier and then a differential amplifier. The differential amplifier, it basically takes the difference between 2 incoming signals. So anything that's the same between them gets canceled out, which is great for canceling out mainline interference, surrounding electromagnetic interference that is the same between 2 incoming wires. So that reduces the noise, and then we can look for the specific frequency changes that we want. So the electrodermal response is quite slow. This isn't like electroencephalography where you're looking for these very fast frequencies. So we just use these low-pass filters that go to an analog to digital converter or sampler so that we can convert the analog signal to a digital signal. The last image here just shows the equipment that you'll be using for this lab. I'll explain more once we get into the lab in person. So overall, that concludes the second half of this laboratory course. I hope that it's been enjoyable, that you've had perhaps a more meaningful experience from just the normal coursework and textbook grind, and actually seen some applications from neurohistology and pathology through MATLAB programming, autonomics, neuroimaging, electroencephalography, statistics and epidemiology, all these interesting things that, all these different ways that you can apply neuroscience to better understand and figure out the world. And I hope you've also realized that learning is not always just a traditional one-dimensional process, but it involves asking a lot of questions and trying to see things in different ways and design clever experiments. And it involves a lot of hard work and a willingness to be unafraid to fail and to tackle challenges and concepts and interesting and intricate ideas that are important for the next generation of science. So I hope you feel inspired to do whatever it is you want to do in life, to forge your own paths, think big, ask hard questions, and don't just do the minimal work required for school, but try to use the tools that you're gaining to really make contributions and solve important big problems. As Albert Einstein said, I have no special talents, I'm only passionately curious. Or Pasteur saying, I'm on the edge of mysteries and the veil is getting thinner and thinner. We should always be on the edge of mysteries and applying our knowledge to make these important advancements. And thank you guys for bearing with me and for all your great questions this semester. And it's been crazy, I know, with the whole pandemic, but I hope you've still gotten a lot out of this course, and I appreciate your involvement and your continued interest in it. So thanks a lot, everyone.